Welcome to Inside SDS. We're so happy to be back with everyone. As you are logging on, please let us know where you're logging on from.
Hi, everyone. Nicole and I are both so excited for the show. This is a guest we've been waiting on the show for 5 years. And you also may have noticed that Nicole and I are together in the same room tonight, which is a first for the first time in 5 years. Nicole and I live in 2 different time zones. So it's a little bit different to be sharing a screen together. I have to move this, though, so I can read the comments, because normally that's in the way of the comments. There we go. Okay. Sorry.
Michelle and I want to personally thank you for joining this webcast. Whether you are a parent, patient, or support person, if you are here, you care about this disease and want to learn more and make a difference. So thank you. We encourage you to tag someone in the comments that you think should also be here. They may not catch it on the live, but they will see it on the replay on YouTube. If you are having trouble commenting, ensure you are logging in on your YouTube or Facebook account.
Yeah. So I think so we have Dr. Bobby on today, who is a pediatric dentist from Cincinatti Childrens Hospital, who specializes in bone marrow failure patients, which is absolutely huge. And I'm just scrolling over to just see who's checking in on the chat. And looks like we have someone from Chicago coming in, from Lansing, which is my home state, even though I'm not there right now.
Thank you guys for logging on.
Thank you guys so much. It's been a fun couple days in Houston so far.
Yes.
It's been very warm, first off.
So people don't know that we've only seen each other 4 times.
4 times in our whole lives.
Total in like 11 years.
The whole time.
Yes. So this is very exciting.
Yeah.
We're going to welcome Dr. Bobby.
And I think maybe in a couple seconds.
Okay.
I mean, in a couple hot seconds, we'll let everyone log in first and make sure that everyone's here. And then we're absolutely welcoming Dr. Bobby, because this is a subject that people have asked for since we started the show 5 years ago. 6 years ago?
6 years ago.
6 years ago. And
2019.
It's exactly how hard it's been to nail down, because it's so hard. Look at the Midwest. Look at the Midwest in the house.
Representing.
I feel I'm bad I'm not there. I'm sorry. I don't know if we have a sign, but Midwest, up, down.
Were you going to throw a gang sign?
No, I was trying actively not to throw a gang sign. My brain told me to stop and not throw a gang sign. So I'll just do this. Midwest.
Okay.
That's not a gang sign. It's my state.
Okay.
That's where I live.
Thank you guys for logging in.
Yes. Thank you, everyone, for being here. This is a subject I think that we've needed in the community for quite a few years. And it seems to be a little bit led by the blind leading the blind. And so we're happy to have Dr. Bobby helping us.
As you were saying,
lead the blind.
We're like really relying on the support group for information, because we've had such a hard time finding someone that's had more than one patient and someone that specializes in this. And we had, to try to book this show, we had contacted everyone that's ever published on SDS and dental issues, and we just couldn't make it work. So they weren't specializing in SDS anymore or weren't available. So
it's definitely been a little bit harder. And I'm very thankful that we finally have it, because it's been something that's been needed.
New Hampshire.
Caitlin is no longer telling us where she's from, which is fine.
We're sharing an earbud also.
I'm sorry. And I move a lot. And so it's going to rip out of her ear, and we're doing the best we can.
This show is also a podcast now. So that's why. Hi, Dr. Bobby. Hi.
Hello, ladies. How are you?
Yes.
We are going to turn the floor over to you. Can we start with the question of how did you get into SDS, specializing in SDS or bone marrow failure syndromes?
Sure. Thank you. I do want to say, first off, I'm honored that the two of you came together for the dental podcast.
This was a big one.
That was that important that you traveled across time zones to get together. So I work at Cincinatti Childrens Hospital, and I have always when I was a resident, my master's thesis was on children who are on chemotherapy agents. And so I've always had a place in my heart, a passion, dedication to children who are going through oncology, transplant procedures. I came to Cincinatti Children's and made a few contacts in the oncology department. And so one of my collaborators, his name is Chris Dandoy, him and I do a lot of work with bone marrow transplant patients, and specifically looking at oral health, oral hygiene, bacterial growth, etc. And then I was really honored that a couple of years ago, the chief of bone marrow transplant offered me a joint position within the division of bone marrow transplant. So they were essentially hiring a dentist for a day a week. So a day a week, I'm theirs. And research, patient care. If they have urgent questions, I go and see patients on the floor. And that has given me the opportunity to talk a lot to physicians, talk a lot to parents, and that experience has given me more knowledge. So then Dr. Koo and Dr. Myers, who are both big in the bone marrow failure world,
Very big.
kind of tapped me for some research projects and clinical care of some of their patients with Fanconi, telomere, and Schwachman. So it's really been kind of trial by fire. I've, read, really talking with physicians, talking with parents, and it's a group of families that, as you mentioned, there's so little information out there. And sometimes what they value the most is having a resource they can go to that can translate basic oral health into kind of for their kids, what stage of treatments, et cetera. How do I translate what's out there? There's so little research, and we were talking about this before. So little high quality research that we kind of fall back on some basic tenets. So my job is really translating a lot of that for parents, for their individual children, because kids are different. So you may have one child that may be totally different than another, and yet those parents are sharing information, but it may not be truly applicable.
Yes. We also want to say you don't have to take notes like crazy for this presentation. We plan to give you a handout or something to give to your local dentist.
Yes. We want you to be fully immersed in hearing and listening, and please asking all the questions you can think you have in the chat. And if we don't get to them, we're going to email them to Dr. Bobby, and then I will send you a personal email back with that answer. And that we just want you to be here and listen to what you need to listen to and hear what you feel like you need to hear. And I love that we have someone from New Zealand.
That's the purpose of
that
this show.
might be a first. I know we've had Australia. I don't know if we've had New Zealand.
Maybe. So that's the purpose of this show, is that we want to grab everyone from around the world that may not have access to this information.
And I mean, I think that's just, it's so wonderful that you can kind of create a safe space, a community for this, because, a lot of the parents, one of the most common comments I get is they feel just so isolated.
Oh,
because
very isolated.
they are, many dentists have never heard of Schwachman diamond. And so having to do the research on what does this mean, it's really intimidating. And I'll be honest, there are parents out there, probably some who are on the podcast, who probably know more than the dentists and physicians, because parents have to become the experts in all fields. You know,
we're thankful for any specialist or provider that knows that we know our kids best, and we just always want to partner with that specialist to help us.
And I love that. And I train residents, and one of the things that's hardest to train is getting them to stop, sit down, talk to the parent, and tell them, well, this is what I would like you to do. How feasible is this? How can we work this? In making that individualized recommendation for each family.
And like you were saying while we were just chatting before the show started, that dental issues tend to fall low on the list of issues to worry about. So it falls under, but it's really important. And it becomes a big thing when there's a problem or the parent doesn't know how to handle it. And so that's why we have you. Are we ready for the presentation? Okay, Dr. Bobby, we're going to give you the floor and then we'll open it to questions.
Sounds great. Sure. The floor is yours, Dr. Bobby.
Thank you. So I think one of the and I talk with my hands, so if that's distracting, I apologize right now. I'm out of my hands are out of frame. So if you see my shoulders moving, that's what's going on. Um, One of the most important things that I am able to share is what recommendations are specific to a 2-year-old, and what recommendations are specific to a 2-year-old with Schwachman diamond. I think that, for a lot of parents, they they think that everything is determined by the medical diagnosis. And the real important things are universal for all kids. And we just tweak the instructions for kids with special healthcare needs. So I think the most important thing is the American Academy of Pediatric Dentistry. And if you go to aapd.org, that is the website, there's actually a Find a Pediatric Dentist link on there where you can put in your zip code and it can give you a list of dentists. But the most important thing is getting into a dentist early. So we ideally want kids to be seen by a dentist by 1 year of age or within 6 months of erupting of the first tooth. And the reason that this is important is not because those kids are all going to have cavities, but because it gives us a chance to talk to the parents about what to expect with teething, with diet, as we start introducing solids and juices. How is that healthiest for a child? The other thing that's really important is that, particularly if you have a child with SDS, the earlier you can link the dentist and the physician managing the SDS, the earlier those two folks can talk, the better. Because there are features that of SDS that can manifest in the mouth. One of the most common is neutropenia. So neutropenia is a common feature of kids with SDS. This means their neutrophil count, which is a immune cell count, is low. Some kids will have a cyclic neutropenia, which means their counts go up and down. Other kids will have chronically low neutrophils, neutropenia. And where this influences the mouth is these kids can be more prone to mouth ulcers, mouth sores. These kids can be prone to losing teeth early. And when I say early, I mean we have 2-year-olds that can lose baby teeth because of the neutropenia. And the reason for that is the neutropenia affects how the teeth are held into the bone. So we have kids who have ulcers and sores who can lose teeth early. Another common feature in the mouth with kids with SDS is bleeding gums. And bleeding gums can also be a sign of bacterial infection. This is what typically we would get called gingivitis or gum disease. And gum disease is a collection of bacteria in the gums that causes the gums to bleed more readily. Where this is important is that the gums are a doorway into the rest of the body. So bacteria can move from the mouth into the bloodstream. And some of these bacteria can cause bacterial infections in the bloodstream. And this is known as bacteremia. And this can be fairly significant for kids who are immune suppressed or immune compromised. So taking care of gums is really important because it helps prevent or minimize that bacteria that gets into the bloodstream. And I should clarify that all of us, whether we have SDS or not, get that bacteremia. So when I brush my teeth, I get a concentration of bacteria that gets into my blood. But because my immune system is functioning fully, it overcomes that, and it's not an issue. The issue is when we have folks who have immune compromise and may not be able to fight off that bacteria. So getting a child to a dentist early, linking the dentist and the physician who manages the SDS and regular brushing help reduce that bacterial infection or bacteria spread in the bloodstream. So other questions that I get very often from the Schwachman patients are, because this is a bone marrow failure condition, that means there is a genetic basis for that. Now, other bone marrow failure conditions include Fanconi anemia. In Fanconi anemia in particular, we notice children have a very high degree of radiosensitivity. This means their DNA is sensitive to any radiation exposure. So when the Fanconi kids in particular go to the dentist, they don't get routine x-rays. Their x-rays are done on a prescription basis when needed. Because our SDS patients are also bone marrow failure patients with a genetic origin, I think being able to justify when we take dental x-rays is really important. What I mean by this is if I have a patient who comes in, so let's say I have a 7-year-old, they've never had any cavities, they have spaces between their teeth, they are brushing really good, their diet is really good, they are what I call low risk for cavities. Those patients may not need regular x-rays. I'm doing those at very specific intervals. Whereas if I have someone who comes in who has very crowded teeth, a lot of previous cavities, they drink a lot of soda, that patient could be at high risk. So I may, in fact, recommend x-rays more frequently. I think what's important is that for parents of kids who have Schwachman, that you ask your dentist, and your dentist should not be offended. What is the reasoning for the x-ray? Is this a screening x-ray? We're just kind of looking at things, or are we looking at something specific? Because with our bone marrow failure patients, we want to minimize ionizing radiation exposure. So, for example, if a child is going to go for braces, there are certain x-rays that are typically standard of care required before we get braces. I would not defer those. But if it's just kind of like, well, we're going to take this because they're at the right age, then I might push back a little bit on the dentist and say, well, we'd really prefer to take the x-rays if you have a reason, a need. There's a national program called Image Me Gently, and you can go online and look up their websites, imagemegently.com. And just like we have immunization cards for kids, where we have the dates and the type of immunization, etc., they have, and you can print this out, it's a little wallet-sized card, and it is every time your child has any kind of radiation exposure, MRI, CT, dental x-ray, you write it down. What this does is this gives your physician and you an idea of the cumulative total ionizing radiation exposure that your child is getting. And again, we don't have evidence on Schwachman Diamond saying, oh, you've got to be as careful as the Fanconi kids. But the absence of evidence does not necessarily mean we ignore it altogether. I still use that principle with all my bone marrow failure treatment patients, that I really want to justify, why am I taking an x-ray? What is my clinical need that I am taking the x-ray for? So the other thing that comes into play is orthodontics, braces. How may braces be affected by SDS? And we, again, just as a common theme, we don't have a lot of evidence. What we do know is that SDS in very severe forms can influence inflammation within the bone. Inflammation within the bone is one reason that teeth move during braces. As the orthodontist puts pressure on the teeth with the brackets, that causes a low level inflammation in the bone that helps move the teeth. And for a healthy patient, that may not be an issue. For someone with SDS, depending on their severity, that could be a significant issue. And so a consult with their physician is key, I think, prior to starting orthodontics. The other thing is the orthodontist may go slower. So instead of putting a lot of force to move quickly, they may say this is going to take longer because we're going to move with a lower amount of force. And I think that's a reasonable and responsible way to approach doing orthodontics in STS patients. And it should really be clear that orthodontics braces are not contraindicated in STS patients, assuming that there's not a lot of periods of severe immune compromise. And the reason I say that is braces, any appliances in the mouth can harbor fungus, namely thrush. It's known as candida. And this fungus can stay on orthodontic appliances. And in patients who are immune compromised, immune suppressed, it can actually lead to an oral fungal infection. So we really want to make sure that the physician signs off from an immune status that the patient is able to get full orthodontic treatment. And I have other areas we can go into, but I'd like to take a stop. And Nicole, Michelle, if there's specific things you would like to direct me to, I'm also happy to do that. I want to make sure I'm responsive to the questions that the folks at home would like me to hit.
There we go. Yeah, so I think that going forward, I know we had a couple of questions here, but going forward, we do plan to have a more generalized pediatric dentistry show and like an orthodontist type show and a couple other specific shows for more in-depth information. Kristen has just came in and said that she's interested in more dental dysplasia or thinning of enamel, which I know we've also heard is a problem.
Yes.
I've heard it's from my breastfeeding, and I wonder what other parents have heard that. I've had a really hard time with my dentist that it's from my breastfeeding, but it's part of SDS, right?
So let me put that to rest right now. Breastfeeding does not cause dental dysplasia.
Thank you.
Okay. So dental dysplasia has many names. It can be called hypoplasia, hypoplastic teeth, enamel hypoplasia, and it is not really understood exactly what causes it. Illness in early childhood, which is when the teeth are developing, can be associated with it. Maternal illness when the child is in utero can contribute to that in the baby teeth. So if while you're pregnant you get very sick, high fever, you are on a lot of antibiotics, a lot of medications, that can influence how teeth develop. With our newborns and our neonates, if they are chronically on antibiotics in early childhood, that can influence how adult teeth develop. And so you can get that
Which one of
pitting.
our kids are not constantly on the most intense antibiotics because they're getting all the viruses. So it all has to, I mean, if they're neutropenic, they have to go through the fever program.
Yes. And so we do see this. I mean, interestingly, there were a couple of papers years back, and what it looked at was kids who got recurrent ear infections in early childhood. Those kids were on a lot of antibiotics. And so those kids had some of these later effects on the teeth. So I think what's important to understand is there are different types. Some have to do with the maturation of the teeth, and some are more of a pitting, where it's hard,
Mhm.
but it's pitted.
Mhm.
Some of these we can just fill in. So basically, like going down the street, filling in potholes, we can go ahead and do that. Some of those require what we call full coverage, meaning a cap that covers the entire tooth to protect the tooth underneath. Because the sensitivity comes from the nerve potentially being exposed through this kind of pitting and all of that.
Interesting. We got another question.
Let's jump to
Yes.
Stacy's.
Yeah, Stacey's.
Yeah, but
And
Greg, can we
I
put that
can
up
see
on the
it and
screen?
well,
I'm looking
Oh,
at
you can
it.
see it. Yeah.
I was
Okay.
thinking about Greg
Yeah.
putting it up on the screen, but it's very long, so I'll
Okay.
just read it.
Yeah.
And Dr. Bobby can see it.
Yes.
How long after transplant, if they're a transplant candidate right now, should she get cleaning done again? We'll start there.
Okay. So one, I would say this is going to be, this is where the dentist and the physician talking are key, because we want a child being prepared for transplant who has optimal oral health. So we don't want their gums to bleed easily. I talked about bacteria getting into the bloodstream. We want to really minimize that. So as long as they are brushing regularly, that minimizes the inflammation of their gums. They can get cleanings. I mean, so I'll tell you, I have kids who are on the transplant list, and I work with my physician colleagues, and I will go clean these kids' teeth every month.
Every month.
Now,
Okay.
that's me. Now, I'm not, you don't have to do the little, the little rubber cup that we use.
Mm-hmm.
It can be a professional toothbrush cleaning and fluoride application. But I do it the more frequent I can, because I'm trying to prepare that kid for the best transplant result. And I don't want the mouth to be part of that issue.
So while they are preparing to go to transplant, you're monthly at that point.
So I will do them monthly. I will do them every 3 months. It's also going to depend on the age of the kid, the number of teeth, and their diet. So related to this, one thing I think I really want to mention is that a lot of antibiotics and pediatric medicines are very high in sugar,
Oh, yes.
because we want
Them to
kids
take it.
to take these medicines. So the pharmacists and the companies make them as sweet and as tasty as possible, because we don't want kids to spit these out. Some of our SDS kids are on long-term antibiotics, and we know the longer term they're on, the compliance goes down. So sugar in these medicines can sometimes be a factor. So a point I make to the parents I take care of, we give all our medicines about 30 minutes before bedtime. Then the last thing we do before we get into bed is we brush teeth. No medicines after we brush teeth. Because what was happening was parents were thinking, well, I'm doing something good by giving them their medicine, they're going to sleep, but then that sugar is just sitting on the
Mhm.
teeth. So 30 minutes before bedtime, all medicines.
That makes sense. That makes a lot of sense.
The next question that came in was also, it's actually just a follow up. She also needs braces. We're about to put them on when we get her SDS diagnosis. Is there a preferred time frame to wait for braces to put them on after transplant?
It's gonna come down to the immune status. So again, every kid's an individual. When I'm teaching our residents, what I typically tell them is, once a child is going for transplant, we are not touching them non-emergently for probably a year. Now we can go in and I can do a toothbrush cleaning, but we're not doing aggressive treatments for a year, because we need their counts to get back up to a normal level. And the physician is going to be able to tell the dentist, for that child, what is the normal level? Where are they going to be and a good place.
I know also most orthodontists want to stick with the same patient. Like you can't just like, if you have to go to Cincinnati, say, for your transplant, you can't just switch to an orthodontist. And am I
Yeah,
correct in that?
we
They're going to have
usually,
to take them
because every
off and start
orthodontist
again,
has their
right?
own treatment plan,
Yes.
and it's you have one case, you get 5 orthodontists in a room, you'll get 25 opinions. So it's kind of not everyone agrees on how to address the issues.
Got it.
We've had 2 kids with 2 different orthodontists, and their opinions were very different, and that's okay because that's their thing. Kristen asked, do we need to worry about enamel thinning now, and can we do anything to stop it or slow it down?
So no, that development is based on the medications and the health status of the child when those teeth are developing. So really we want the child as healthy as possible, which is what every parent wants too. So I think it's more of a case of preparing if they are chronically sick, chronically on antibiotics and medications, just preparing that there could be issues with how the enamel of the teeth are.
And then what should they look for when the child does start getting his adult teeth, and will the same thing happen again?
So the adult teeth, once they're in, it's not going to happen. It's while it's developing.
Okay.
So while it's developing, if the child is sick or on lots of medications, that's when we would see it at that later date. What you'll see is as teeth come in, they might be yellow. They might be very, very, like have a white spot on them. These are signs that something during development changed how the tooth was forming.
Got it.
For patients that currently have caps on their baby teeth, is it anticipated that they will also have similar enamel issues with their adult teeth? I think you kind of answered this a little bit with the last question. And if so, is there anything that can be done in
Yeah, and I
preventative
think the
manner?
other thing to prepare is yes, but is it capped because of enamel thinning or is it capped because of cavities? So an interesting study that I did must have been about 7 or 8 years ago. This is on kids we saw in our clinic, not SDS kids, but kids 0 to 3, and we just surveyed parents. What do they drink? What do they drink? 20% of our kids drank soda in their sippy cups, 3 and under.
0 to 3.
0 to 3.
How
So
much?
soda,
20%?
sweet tea, yes. Sweet
Interesting.
tea. If you look at the American Academy of Pediatric recommendations, juice is not recommended for our really, really young kids. So what I tell parents is they can have juice, but they should have it with a meal. So if they have a sippy cup and they're walking around the house, that should only be water. That should
Okay.
not be juice.
My 2-year-old is predominantly on toddler formula, which I know is high sugar. Do you have a recommendation for a good toothpaste to use?
So it's a wonderful question because it brings up another point. The reason the medical team and the dental team should connect. Some of these kids have chronic weight gain issues,
Mm-hmm.
and their physicians and their dietitians are telling the parents anytime you can get them to eat or drink, you give it to them because they need to gain weight. So we do not want to contradict that. The physicians and the dietitians are more important because we need the child's overall weight to be good so their brain development, everything else will be good. What this could mean is that you may be brushing your child's teeth more frequently. And any toothpaste with an ADA seal of approval, you can see it on the back of the tube, is recommended. The interesting thing is if you look at adult toothpaste and kids' toothpaste, the fluoride content is no different. The only difference is the flavoring. Kids' toothpaste, if you've ever tried it, is extremely sweet. And again, they're trying to get kids to use it. Adult is minty usually. But if you started your kid on a mint toothpaste when they were little, they will probably be totally fine with mint. So the other part of it is the amount that we use. So you look at commercials and they had this big ribbon of toothpaste that they put on.
Mhm.
Totally wrong. We want a size of a grain of rice.
Grain of
So a
rice?
tiny, yes. So a
My kids are
tiny
about to be
amount,
so excited. So excited.
a tiny amount. And what you do is you brush the teeth and then you don't rinse out the mouth. So the toothpaste is staying on the kid's teeth.
I
But it's
thought
that
drinking the
small amount.
fluoride was bad. No? Am I wrong on
What's that?
that? I thought
So it's
drinking the
if you
fluoride was
that's only if you have those large amounts. That small amount, size of a grain of
the
rice,
rice.
totally fine. Totally fine.
Interesting. Okay,
And
so
that
if
is
you swallow it,
3 and under.
what does it do if you swallow it and don't spit it out?
So if you, let's say, worst case scenario, child opens toothpaste and like eats half of it,
Yeah.
It's
what
happened.
that can do is cause heart conditions,
Oh.
and I mean, you would call poison control at that point.
It's true.
I thought there was something with like white spots on the teeth or
So you can get what's called fluorosis
okay, that's
if
what it
you
was. Yeah, okay.
use too much toothpaste too often. So if you use that big ribbon of
Ribbon
toothpaste
that they're
on a 3-year-old,
advertising. Okay.
that's going to be too much. So that's why we say just that rice size, 0 to 3, and 3 and up, they say a pea size. So it's still a
Interesting.
very small amount.
Well, speaking of the amount that's needed, we had a question coming from Stacy. um, she's trying to brush her kid's teeth, but it's a complete nightmare. And is there anything else she can try to do to help brush his teeth? He has a lot of oral aversion from being
Yeah.
force-fed Creon.
Which a
Yes.
lot of our kids have
Yes.
because of Creon.
Yeah. I will say that some of the parents, and this is where no evidence, but I value the opinions of parents. So when I see kids with really good teeth, I ask the parents, what do you guys do? Because I want to know what works. And so one thing is there are these toothbrushes, which is it slides on your finger. It's like a little rubber
Mm-hmm.
toothbrush. And you can put that in and you can essentially massage the gums. And it's not like a toothbrush that's more difficult. So an interesting thing about that is if you brush your own teeth and you brush too hard, there's a feedback loop. And that tells you don't brush so hard. However, if you're brushing your child's teeth, there's no feedback loop. So the child tends to pull away. So what they have shown is we brush other people's teeth harder than we would brush our own teeth. So I think trying to do something like using the little finger toothbrush would be a good place to start.
That's a great advice. Yeah.
We had a question come in from Stacy that says the yellowing is very interesting. I wondered why hers were yellow. Can they be whitened, or is that not good for their teeth? And then she clarified that as they're an adult, with adult teeth,
Yes.
can teeth be whitened?
So once they're an adult, they can be cosmetically treated. The main reason we don't try to do it when they're younger is the nerve of the tooth is still immature. And excessive bleaching or whitening can actually lead to nerve sensitivity and ultimately nerve injury.
Not good.
So we try to wait until they're a little bit older. This makes it really challenging because kids in school are mean. So if you have a kid who has kind of a weird looking tooth, that can be a social issue. So in those cases, we do a cap and we cover the whole tooth. If your child is having esteem issues, social integration issues, things like that.
Jennifer Alvarez asked, for SDS specifically, are enamel issues inevitable? My 3-year-old currently has normal seeming enamel and healthy teeth. We brush twice a day and floss, concerned about the future. That's a good question. Like if you're.
Yeah, and no, it's not inevitable. It's not inevitable.
Mhm.
It's going to be based on the severity of the SDS, the immune status. Were they immune compromised? Were they on a lot of medications and antibiotics? And at what stage and for how long? So it definitely is not inevitable. I'm happy to hear that currently everything looks normal. That's great.
Leah Hiles jumped in, and I know Leah because she's from Australia. So for patients who do not have any major immune problems and their blood counts are okay, can we expect that orthodontic appliances like expanders would work like they should traditionally do on non-SDS kids?
As best as we know, yes. Again, I don't have any evidence to conclusively say that, but it is the immune issues, the issues with inflammation that can complicate orthodontic treatment.
We had one last question come in and we jumped around a little bit, so I'm sorry, but Britannia asked, is there anything that we need to worry about post-transplant to look for? And I'm assuming specifically post-transplant versus pre-transplant of what mouth care should look like.
So it should not look any different. And there was a question, and I'm going to tie it to this. It was Caitlin's question, which is younger kids. So kids cannot reliably spit till they're about 6 years old. So anyone under 6, they're going to swallow more than they spit. So that is why we focus on a small amount of toothpaste, because we know they're going to swallow most of it. But related to the post-transplant, it's going to be dependent on the age and what teeth we're developing during the transplant period that you may see issues.
Had a question come in from Mary, and I know this personally because my son has a lot of lung issues. I guess what precautions should we be taking if our children are consistently on inhalers and nebulizers in relation to mouth care?
Yeah, and that's a great question, because I mentioned earlier that immune compromised kids could be more prone to oral fungal infections like thrush. Inhalers are known. Chronic inhaler use can cause fungal infections of the gums. So the recommendation is, if you're using an inhaler, you're using a spacer. And a spacer has a mask and then a long chamber, and the inhaler is attached to the chamber. And then that goes over the child's nose and mouth, and they breathe it in, versus them putting the inhaler directly in their mouth. And your primary care physician should be able to give you a spacer.
Okay, I think that's all we have time for today. If you have any questions, message us. We will probably have Dr. Bobby on again because this is such a popular show.
Yes.
Dr. Bobby, thank you so much for your time today. I know you're traveling, you're at a convention today, and you still made time for us. And thank you for specializing in helping patients like ours. Thank you to everyone for joining us today. Huge thank you to Dr. Bobby for jumping in even on while he's traveling. The subject was...
I do want to give you two a shout out, because creating a space like this for families is so important. And
Thank you.
How do we do it? How do the young ones do it?
Thank you. That's how the younger ones do it.
I don't know how the young ones do it.
Thank you. So we're just two moms. You know that. We're just two moms.
Did you just give me the finger? What was that?
No,
we're trying to do a heart.
I'm joking. I'm joking.
I would never.
Any of my families, I will recommend this to them, because
thank you so much.
It's always better when you feel you're part of a community. And I treat a lot of kids with special needs, not only our oncology kids, but a lot of older adults with intellectual developmental disabilities. In those families, the most common thing is sometimes they want to talk to someone. And I have learned from mentors before me that I spend probably the first 10, 15 minutes of my appointments sitting down and talking to the family, because I know when I go to the doctor and they turn away and they start clacking on the keyboard and everything, it makes me feel like I'm an imposition. But we're so fortunate to be able to take care of these families and these kids. So you guys are doing an amazing job, and I will come back as many times and whenever you need me to.
Say what you mean. Say what you mean, Dr. Bobby, because we've got a lot. And I really appreciate that throughout the whole thing. You could see there was a clear need for both pediatric and orthodontic and young adult. And
Transplant,
so
Yeah.
I did post that we are planning on to do more with Dr. Bobby because
And
we know this is a big subject.
I'll start getting my orthodontists in line.
Ready.
Thank you.
Ready to
you know,
go.
Yes.
And we said at the top of the show, you didn't have to take notes. We were going to send you notes.
Yes, we've
we'll
got you
send
for
you
notes.
something.
We've got you.
We'll send you something that Dr. Bobby approves to give to your dentist, and you're not alone. And the biggest feedback we get is that they don't feel alone because they see us together, even when we're in two different.
But we're not normally together. This is a very rare occurrence.
Well,
very rare.
I guess you're just gonna have to move to Houston. So
maybe
I don't know.
I don't know. I really like where I live.
I'm okay with
I really
that.
like the Midwest. I'm sorry, but maybe once a month we'll see.
Okay.
Before we end the show, though, please comment if you are a patient, a parent, guardian, or support person in the SDS patient's life. If you are a support person, we'd love to know more how you support the patient, because you're also a pivotal part of this team, whether you're a grandparent, a teacher, a therapist, or maybe even their doctor. We've had this show sent to doctors. It's not just for patients and their families. We are here to make the lives better all the way around in the best way we can. We want this show to be helpful to anyone that needs to hear this information.
And thank you to everyone for joining us. Thank you for Dr. Bobby for jumping in. Thank you for Greg behind the scenes who does all our tech issues.
He's there.
A reminder, you could find all our shows on YouTube, and we will be converting this into a podcast so you can listen to it as well. You don't have to sit there and watch it for an hour.
You don't. You can just listen to us for an hour. It'll be a great time.
Thank you, everyone.
Thank you so much, everyone, for being here, and we're so appreciative of you. Thank you so much. Have a good night.
Bye-bye. Thank you.
Bye.